Hello everyone, welcome to my channel. Today I'm going to discuss 3 practice questions. So let's get started. So the first question is, which syndrome is characterized by downward slanting of palpebral fissures and hypoplasia of mandible maxilla and zygoma? So read the question again. So it's saying that there is downward slanting of palpebral fissures and hypoplasia of mandible, maxilla, and zygoma. So here are the pictures of 4 different syndromes, and the options that you have for this question is whether it is Down syndrome or Marfan syndrome or Pierre Robin syndrome or Treacher Collin syndrome. So again, see the screen, the 4 different types. So let's get started. This is Down syndrome, the first diagram. All right. So I'll write down the points over here so that you remember along with the picture. So here you see a mid-face skeletal deformity. And also here you see eyes are like almond-shaped eyes, right? And they're upward slant. Here you can see the downward slant of the eye. Okay, so in the Down syndrome, there is mid-face skeletal deformity. And you can see that there is almond-shaped eyes. There is upward slanting of the eyes. So upward slanting palpebral fissures can be seen. Okay. Now, in the Marfan syndrome, the person will be tall, but he'll have a lot of spasms. Okay. And he might also experience abnormal chest and heart activity also. Now, this is Marfan syndrome, where the person is tall but has spasms. So here, their oral findings are they have high arched palate. And also you can see there is a lot of dental crowding. Okay. Then here, the next syndrome is Pierre Robin syndrome. So what happens in Pierre Robin syndrome is here you can see micrognathia. So micro means small, gnathia means jaw. So here you can see that the jaw is really small. It's not normal. So in these patients, there is small jaw. So therefore, when they are fed, there will be a problem. But then later it becomes normal by the age of 4, and by 6, usually they'll be healed. But sometimes there might be some problems, very rarely, which might have to be treated at a later stage. Now we come to Treacher Collin syndrome. Now what happens in Treacher Collin syndrome is the person looks like the facial appearance is bird face or fish face appearance can be seen. And then here there is hypoplasia of mandible, maxilla, and zygoma. So there is less number of cells in mandible, maxilla, and zygoma, and also external and middle ear. Even the ears are small. All right. And always there is some linear colobomes of the outer third of lower eyelids, which are seen in 75% of the patients, and lower eyelids are absent, and there is always a problem with their eyes. Like you can see, Down syndrome and Treacher Collin syndrome, do not get confused. They both have a deformity where there is a skeletal deformity and the eyes have a problem with it, but then they both are different. Okay, because in Treacher Collin syndrome, you see downward slanting of palpebral fissures. Whereas in Down syndrome, it's upward slanting of palpebral fissures. So this is really important according to the exam. So because read the question, if they ask for upward slanting palpebral fissures, then it's Down syndrome. And if they ask downward slanting of palpebral fissures, it is Treacher Collin syndrome. Now, next question. Patient with CNS disorder comes to dental office and dentist after oral examination asks him how often does he brush his teeth. Patient says that he cannot see how much paste he puts on his brush, but he does brush his teeth 2 times a day. Which lobe is affected? So doctor is asking patients, how many times do you brush your teeth? So he says, I cannot see how much toothpaste I'm putting, but then I brush it 2 times a day. So we have 4 lobes. We have frontal lobe, parietal lobe, occipital lobe, temporal lobe, and all are connected by corpus callosum. Okay, so frontal lobe defects. Now, first I'll explain what are the different functions of the lobes, and then you can try to answer. So frontal lobe is mainly for motor cortex, and parietal is somatosensory in function, and occipital lobe deals with visual cortex, and temporal deals with auditory. Now, example is, suppose you need to walk. If you have to walk or run, the lobe responsible is frontal lobe. Okay. And if you have to, suppose you touch a very hot cup, then you immediately push back. You won't keep on holding it. That is because of your parietal lobe. You are able to see things if like there's something, a vehicle coming in front of you, you're able to see it because of occipital lobe functioning. Then you're able to hear well, that happens because of temporal lobe functioning. So here the patient is not able to see properly, then it means there is a defect in occipital lobe. So the answer is occipital lobe. All right. Now, in Parkinson's disease, why is Carbidopa used along with Levi Dopa? So in Parkinson's disease, what happens? There is a dopamine deficiency, right? So what happens? You can think that, okay, let me just, so this person is suffering with Parkinson's disease, I will just inject dopamine. It does not cross the blood-brain barrier. So what you have to do is you can give it in the form of Levi Dopa. Levi Dopa does not cross the blood-brain barrier. We need it to be converted into dopamine only in the brain. So let me just explain again. So in Parkinson's disease, there is dopamine deficiency, and you can inject Levi Dopa. What happens over here is it does cross the blood-brain barrier, but the thing what I was trying to say, sorry, I was trying to say this and I said it in a different way. So when you inject Levi Dopa, what happens is it is converted into dopamine before it reaches the brain itself. And what we need is we need it to be converted into dopamine only inside the brain, not outside the brain. So in order for the Levi Dopa to convert into dopamine before it reaches the brain, so what can we do is we can give Carbidopa along with Levi Dopa. So then what will happen is Levi Dopa, when given along with Carbidopa, is converted into dopamine only in brain. Okay, so the main reason we give Levi Dopa is it crosses blood-brain barrier. So I'm sure now you're not confused. So again, I can repeat. So in Parkinson's disease, there is a dopamine deficiency. So therefore, we need to give dopamine. So what happens is when we give Levi Dopa, it gets converted into dopamine before it reaches the brain itself. So therefore, Levi Dopa is given along with Carbidopa so that it will cross the blood-brain barrier, reach the brain, and then only get converted into dopamine. That is the reason why Carbidopa is used along with Levi Dopa. Okay, so I hope you have understood all these 3 questions, and in case you enjoyed the video, please do like, share, and subscribe. And thanks for watching.